Okay, gotta go. We will have a lot of time to discuss in between coffee breaks. What do we want to do? So my last few minutes, I think, which I learned a lot in my career in this field, is the psychological mindset and CTO complications. I don't have anything. So it always starts, why are you giving that therapy? Why are you doing that? And it's a tale of two patients. One has stable ischemic heart disease, class 2 angina, 2 anti-anginal medication, select appropriate therapy to reduce future cardiovascular events, significant single vessel coronary artery disease, right? So you got one on the right and the one on the left. This is what I've been telling you just 30 seconds earlier. So one is a CTO, one is a long non-CTO lesion. So guess which one in general gets treated? The one on your right. You put a wire, balloon, use the image, and you're done. The one on the left, you will think twice. You may increase the beta blocker, give nocorandil, and so forth. So this is a question of why. Patient 1 gets treated, patient 2 does not. You keep on checking them, giving them more medications, more angiograms, more stress tests, seeing to see if the non-CTO vessel is progressing or giving the patient a symptom. So it's absolutely important when you have these cases to really think about the risk and benefit. Risk and benefit will stratify you whether you're justified to doing the procedure. So if the patient, for example, when you have a STEMI patient, the benefit is high, the risk is typically low, you'll do it. So if the risk is high and the benefit is low, including CTOs, calcification, angulation, shock patients, whatever, don't do it. Really be careful of doing those cases because the benefit is low. So, and I'm sure everyone does that. It's just a matter of consolidating that information that when you leave, and I'll show you something in the next few slides, but keep this in your mind. So the leading edge, the leading edge of failure and risk, you need to think about patient comorbidities, surgical ineligibility, what are the hemodynamics and the ventricular function of the patient, and how complex is the anatomy, and what about the target vessels. So as mentioned by my good friend Hani and the rest of the colleagues this morning, CTO complications are high, really high. They're not, these are procedures associated with bad outcome, so you got to be careful. So, but why did this happen to my patient? And for you at that moment, you say, and why me? Hani does it, Khalid does it, I don't know who does it, but why it happened to me? It's just gonna happen. So this is a case where you have contralateral vessel thrombosis if you don't check your ACTs. I've talked to my Mavericks on my team, we check ACT every 20 minutes. They will bombard me, they will yell at me, I need ACT. I will say, just give me a second, I need ACT. And rightly so, because I don't want this to happen. So the contralateral feeding vessel got thrombotic. And now we are in deep trouble when this happens. And then, oh, my poor patient, what have I done? You will say that to yourself, but you'll be quiet. What was I thinking? I shouldn't be doing this. They're all going to think that I am terrible. What am I going to tell the family? They're there waiting. Unemployment, here I come. Dr. Fuad's going to call me to his office. So, if a patient has a complication and dies, the question would be, did the operator do something wrong? Or if the patient lives, did the operator do something right? So 10% of physicians post-complication feel that their ability to perform the job is impaired. How many of you who had complication felt happy next day? None. You'll go home depressed. You will not talk to your wife, to your family. It takes you time to recover. A significant percentage avoid certain procedures as a result of previous complication. Those who had negative outcome reported difficulty concentrating, declining clinical judgment, loss of confidence, trouble sleeping, and difficulty enjoying leisurely activities. That is called what? Major depression. Frequent percentage of physicians post-complication report symptoms of frustration, embarrassment, anger, blame, worry about your reputation, and reduced job satisfaction. And this is called what? PTSD. So when a procedure complication happens, there's peer review, you'll be called in for M&M, patient safety board, risk management. And when a physician does make a mistake, it is whispered about in the halls as if it were a sin. Much later, a case conference is called in which experts who have had weeks to think about the situation and who have never done a case like you discuss the way it should have been handled. It is only permissible to talk about mistakes when they happen to other people. This has been a quote in New England Journal of Medicine. So who's your savior? Call Hani, call Khalid, call your friends. Say, look, this had happened, and the community is too small, and this is why I like what Fawaz has done with the team at the GIS to have a course like this. So we have a community. If something goes and you think that you need to talk to one of us, communicate, give us a call at any time. Look, this is what's happening. How could it be better? So the purpose of these meetings is to get people together that I trust my colleagues. Those are the ones who are going to stand with me and support me during these problems. So procedure complication, you have the online trusted colleagues, but what would you think? What would people do? You're selectively ignorant sometimes. You will see a perforation somewhere and you say, it's okay, nothing's going to happen. Or you say, well, you know what, this is an act of God, or it's a human error. So the reality of what we do is, well, obviously I had no complications. I'm a fantastic operator. I never have any complications. Actually, I've seen people saying that. But it's the issue of Dunning-Kruger effect. And I urge every single one of you, and I've talked about this several times, to study this. This is Dunning and Kruger got Nobel Prize in psychology for this. Only one curve. So your confidence and your experience time. So and this is for the early career risers. When you start in this field, you're novice. Do not be overconfident, because this is what I call Mount Stupid. This is where you're going to get troubles. This is when you get frustrated. But as you advance in experience and something goes wrong, you will be in the valley of despair. You say, well, I've been doing this for 5-10 years, and I'm getting a complication. Is there something wrong with me? What have I done? Am I getting older? Is my skills not good enough? Should I quit? But as you become an expert, you will have the slope of enlightenment that no, I learned and I'm getting there. You are never going to be 100% confident. So if you leave with this talk, please, please, please Google Dunning-Kruger effect. It's an amazing concept that it would help you in anything, not only complications. So again, back to the reality of what we do. Well, obviously I have no complication, but that's only because you do no cases, right? You have zero complication. Don't do it. Don't tell your problems to people. 80% don't care. Another 20% are glad you have it. And I'm sure, no, I'm not going to give you depression. It's the reality of it. I am sure there are people, if you're successful, you'll have enemies. So get with your trusted colleagues and friends. So when you make a mistake, there are only 3 things that you should ever do about it. Admit it, learn from it, and don't repeat it. So lessons learned. So complications are inevitable in high-risk PCI. Big data, like what my colleague Hani showed, guide us to identify high-risk situation, but ultimately, a systematic analysis is necessary to identify the root cause and how to avoid it. We systematically use a form in our cath lab. It's called PETAL form. Any complication that happens is documented, not to go to litigation, not to go to the administration office, that we review them and how to avoid this in the future. And we support our staff. Need a way to systematically organize and analyze your individual experience too. So what are your professional goals? You share the experience so we don't repeat each other's mistakes. That's like what we're doing in here. Improve the knowledge base of options to treat and avoid complication, learn and share. Develop structured work process, checklists, algorithm. We use the PETAL form to minimize the consequence of complication. And you know what? Get help from the right person. I don't know if anybody knows Steve Magnus. He's an amazing guy. He's a very important coach. He's well-written, many books. So great performance. Before that, you need to manage your identity of what you do. What you do is not who you are. Don't you ever think you're a great operator that is going to make your identity better. Who you are is who you are. So, great performance, learn to separate identity from performance. A bad race does not make you a bad runner. A tough meeting does not make you incompetent. Missing the mark does not make you, does not mean you don't belong. But if your ego ties every outcome to your worth, you live in a fear of the next test. And fear suffocates growth. You will never see what you're capable of or approach your limits. And a complication does not make you a bad interventional cardiologist. Failure to achieve a goal does not make me a failure. It means I tried, but I did not succeed. Now I must work out how I can help myself to improve and succeed next time. It does not mean I should give up. To achieve our maximum potential, we must separate ego and identify from performance. And don't forget, you're a human too. Take care of yourself. You have many lives to save ahead of you. Get off the wheel regularly. It helps you to evolve as a true selves, improve perspective to achieve greater professional success without compromising personal fulfillment. We all do that. I try to do that as much as I could, but it's a commitment for you to be on the wheel. With that, I thank you very much for your attention.